All right, future doctors, welcome. We're about to dive into one of the most fundamental skills you'll ever learn in surgery, assessing the acute abdomen. Look, this isn't just theory. Getting this right is absolutely essential for your clinical years. So let's get right into it. I want to start with a quote from the great Sir William Osler, one of the fathers of modern medicine. He said, "Listen to the patient. He is giving you the diagnosis. This is our guiding principle. It's all right there. The patient has the clues. Our job is to become skilled detectives and uncover them." So here's our game plan for today. We're going to follow the exact sequence of a real patient consultation. First, we'll talk about why this bedside skill is so critical. Then we'll get into gathering our clues. That's the history. After that, we'll decode the most important clue of all, pain. Then we'll analyze the physical evidence. And finally, we'll talk about what to do when the case isn't so clear-cut. Okay, so let's start with the big picture. We live in an age of incredible technology, right? CT scanners, MRIs. So why are your hands, your ears, and your clinical judgment still the most important diagnostic tools you have? Let's break that down. This is the absolute core principle. I know how tempting it is to just jump the gun and order a scan. You have to resist that urge. You want to know why? Because the most crucial make-or-break clues are found right there, at the bedside, not in some image from the radiology suite.
All right, let's move on to phase one of our investigation, gathering clues. This is the art of history taking. And trust me, it is so much more than just running through a checklist of questions. Think of this as your roadmap. You start broad, right? You let the patient tell you their story. That's the presenting complaint. That story helps you start to guess the organ involved. From there, you start to refine your ideas with really specific questions. And finally, you fill in the rest of the puzzle with their past history and a full systems review, just to make sure you haven't missed a thing.
Now, in an acute abdomen, pain is almost always the central clue. It's the big one. But just knowing it hurts doesn't help you much. See, not all pain is created equal, and learning to decode its specific character, that is how you're going to crack the case. So here's the first major distinction you absolutely have to understand: the difference between visceral and somatic pain. Visceral pain comes from the organ itself, is that deep, dull, achy feeling that's hard to pinpoint. The patient might kind of wave their hand over a general area. But somatic pain, that's totally different. That's when inflammation touches the lining of the abdomen, the peritoneum, and that pain is sharp, it's intense, and the patient can usually point to it with one finger. And this leads us to another classic concept, referred pain. This happens because different parts of the body can share the same nerve pathways. The textbook example, and you will see this again, I promise, is diaphragmatic irritation. The nerve that goes to the diaphragm, the phrenic nerve, comes from the C4 level in the neck. Well, guess what else comes from C4? The nerves to the skin over the shoulder. So if blood or pus is irritating the diaphragm, the patient feels it as pain in their shoulder tip. It's a fantastic clinical clue. So with all that in mind, your first question every single time is this one: where is the pain? That is your starting point. It's your primary geographical clue, and the answer immediately helps you narrow down your list of suspects.
And to talk about that location precisely, you need to know this map, the 9 abdominal regions. This is the language we speak in surgery. You've got to know this grid like the back of your hand, because you'll be using it every single day.
And here is where that map becomes so powerful. Each location points to a likely list of culprits, right? Pain up top in the epigastrium, you start thinking about the stomach, maybe the pancreas. Pain down in the right iliac fossa, appendicitis immediately jumps to the top of your list. This is exactly how you start building your differential diagnosis.
Okay, so we've taken our history, we've got a list of suspects in mind. Now it's time to gather the physical evidence, and we do that through a systematic, hands-on examination of the abdomen.
Now listen, the sequence here is non-negotiable. It's not a suggestion. You must do it in this exact order. Look, then touch, then tap, then listen. Inspection, palpation, percussion, auscultation. Why? Well, think about it. If you start poking around before you listen, you can completely change the bowel sounds and get a false reading. The sequence is everything.
So during your inspection, you're looking for things like scars or distension, but also keep an eye out for these rare but classic signs: Cullen's and Gray-Turner signs. That bruising you see there, it's caused by blood tracking from deep inside the abdomen. If you see this, it is a dramatic and very serious finding, often pointing to something like severe hemorrhagic pancreatitis.
Okay, when you move to palpation, you've got to be gentle, and you always start furthest away from where the patient says it hurts the most.
You're feeling for signs of peritoneal irritation. It might just be tenderness, or it could be guarding. That's when the muscles tense up involuntarily. But the most extreme form is rigidity. If you feel an abdomen that is board-like, rock hard, that's a surgical emergency. That means generalized peritonitis. Here's a beautiful example of how a simple physical maneuver can be incredibly diagnostic. This is Murphy's sign. You place your hand in the right upper quadrant, and you ask the patient to take a deep breath. As they breathe in, their diaphragm pushes their inflamed gallbladder right down onto your fingers. They'll feel a sharp jab of pain and immediately stop breathing in. That little catch in their breath is a classic sign of acute cholecystitis. And finally, we round out our sensory investigation with percussion and auscultation. Tapping on the abdomen can tell you if it's full of resonant gas or dull fluid. And then listening with your stethoscope helps you differentiate between, say, the high-pitched tinkling sounds of a bowel trying to push against a blockage versus the scary silence of a paralyzed bowel, what we call an ileus. Okay, so what happens when you've gathered all your clues, you've done a thorough examination, but the diagnosis still isn't clear? This is where one of the most important and, honestly, one of the most difficult skills for a young doctor comes into play. And the crucial point here is this. When you're in doubt, sometimes the best course of action is to wait and watch. Admitting a patient for what we call active observation isn't a failure to diagnose. It's a powerful diagnostic tool in itself. Watching how the symptoms and signs change over a few hours is often the most revealing test of all. So, I'll leave you with this question to carry with you onto the wards. In our era of advanced imaging, what is the one clue you can only get from your own two hands? It's tenderness. A CT scan can show you inflammation, it can show you an abscess, but it can't tell you if it hurts. Finding that out, well, that's your job. Never ever forget the power of that.